Welcome. I think 118 ሰው ጆይን አድርጎናል መጀመር እንችላለን። ይሄ የጤና ወግና ኢማ አንድ ላይ በመሆን ሬጉላርሊ የሚዘጋጅ ሲኤምኢ ሴሽናችን አንዱ ነው። ለሜንታል ሄልዝ ቶፒክ ደግሞ 2023 ከጀመርን የመጀመሪያው ቶፒካችን ነው የሚሆነው ሶማቲክ ሲምፕተም ዲስኦርደርስ ወይም ሳይኮሶማቲክ ዲስኦርደርስ ላይ ነው ዲስከስ የምናደርገው። የጤና ወግ እንግዲህ ከዚህ በፊት ጆይን አድርጋችሁ ለምትከታተሉ ብዙ የአድቮኬሲ እና ተጨማሪ ስራዎችን እየሰራ ይገኛልና ይህም ሲኤምዩ ፓርት ኦፍ ኢት ነው። ከዛ ውጪ ክለብ ሃውስ ላይ ምናልባት ጆይን ያላደረጋችሁ ሰዎች ጆይን እንድታደርጉ በየጊዜው በየሁለት ሳምንቱ የሚቀርብ ዲስከሽን ይኖራል። ሜንታል ሄልዝ ብቻ ሳይሆን አጠቃላይ ጀነራል ሄልዝ ላይ እዚህም ከሲኤምኢ ላይ በተጨማሪ ብዙ አክቲቪቲዎች አሉ እና ዌብሳይቱን ክለብ ሃውስን ፌስቡክ፣ ትዊተር እንዳለ ሶሻል ሚዲያዎች ላይ ፎሎ እንድታደርጉ ጋብዛችኋለሁ። የዛሬው ቶፒካችን የሚሆነው ስክሪኑ ላይ እንደምታዩት ሶማቲክ ሲምፕተም ኤንድ ሪሌትድ ዲስኦርደርስ ላይ ነው የሚሆነው። ይህንንም እንግዳችን ለዛሬ ዶክተር ቢንያም ወርቁ ነው። ዶክተር ቢንያም የሳይኪያትሪስት ነው። እንዲያውም በተጨማሪ ትራውማ ሰብስፔሻሊስት ነው። የመጀመሪያ የሕክምና ዲግሪውን ጅማ ዩኒቨርሲቲ አግኝቷል። ከዛም ስፔሻሊቲ ሳይኪያትሪ ስፔሻሊቲውን በአዲስ አበባ ዩኒቨርሲቲ አሁን በአዲስ አበባ ዩኒቨርሲቲ በማስተማር እና በማገልገል ላይ ነው። እንዲያውም በተጨማሪ ቶሮንቶ ዩኒቨርሲቲ ደግሞ ትራውማ ሰብስፔሻላይዝ አድርጓል። እኔንም ጨምሮ ብዙዎችን እያስተማረ እና እያሳደገ ነው። በሪሰርቾችም ላይ አክቲቭሊ ፓርቲሲፔት ያደርጋል። እንዲሁም ናሽናሊ ስፔሻሊ አሁን ደግሞ ትራውማ ላይ ከሀገራችን ጋር ካለው ኮንፍሊክት በተጨማሪ ደግሞ ብዙ አክቲቪቲዎችን ሰፖርት ያደርጋል። እንዲሁም በተጨማሪ ሴሬኒቲ የሚባል ኮንሰልተንሲ ከፍቶ ደግሞ እዚሁ ተመሳሳይ ትራውማ ላይ ብዙ ስራዎችን እየሰራ ይገኛል። ከኔ በላይ ግን ራሱን አስተዋውቆ እንዲጀምር ዶክተር ቢንያም እንጋብዛለሁ።
Thank you, everyone, for the kind introduction. I don't know, I don't think I can add too much on top of what you just said. I just would like to welcome everyone to this webinar, and I would like to thank Yetenaweg and IMA for creating this platform and also for giving me the opportunity to be part of this endeavor. So for today, my talk will focus on somatic symptom and related disorders. In the past, this group of disorders were known as somatoform disorders, and that's why in our poster it says somatoform disorder. That is a nomenclature that we used in the past, but the current nomenclature is somatic symptom related disorders. As most of you know, nomenclatures change quite often in psychiatry. That's one of our things. So without further ado, I'm going to start my presentation. Unless Herman, is there anything else you'd like to say before I start?
ይቅርታ, one more thing, sorry. ትንሽ አንዳንድ ሰው ድምፁ ትንሽ እያስቸገረ ነው የሚል ሰው አለ። ምናልባት እሱን ድጋሚ ቼክ እናደርጋለን። ግን ለሲኤምዩ ኢማ ክሬዲት ይሰጣል። ሰርቲፊኬቱ አቬይላብል ነው የሚሆነው። ልክ ከአንድ ሰዓት ፕሬዘንቴሽን በኋላ እንድትመዘገቡና ጥያቄዎች እንድትመልሱ ቻት ቦክስ ላይ ሊንክ እንልክላችኋለን። በዛ ሊንክ መሰረት 50% ላገኘ ሰው ሁሉ ሰርቲፊኬት ይሰጣል። ሜቢ 2 እስከ 3 ሳምንት ሊፈጅ ይችላል፣ ግን ኮሚዩኒኬሽኑ እንቀጥለዋለን። ምናልባት ኦዲዮን ድጋሚ ቼክ እናድርግ መሰለኝ። አንዳንድ ሰው ኦዲዮ እየተሰማ አይደለም እያለ ነው። እስቲ ዶክተር ቢንያም ድጋሚ ኦዲዮን ነው ያስተጋባ ከሆነ ቼክ ለማድረግ።
እሺ
አይ ቲንክ መቀጠል እንችላለን። ይሰማል። ለእኔ ይሰማኛል።
ኦኬ፣ የሚያስተጋባ ነገር አለ አሁን ወይስ should I go ahead?
ጥሩ ነው። We can continue.
Okay, thank you so much. Somatic symptom and related disorders. So in terms of somatic symptom and related disorders, somatic concerns and pervasive and overwhelming thoughts and behaviors centered on these sensations are the core of what we call can you guys hear me? Okay, so I'm just going to continue. If anyone is having difficulty with audio, please let me know. So somatic symptom and related disorders. Somatic concerns and pervasive and overwhelming thoughts and behaviors centered on these sensations are the core of this group of disorders. So this group of disorders include 5 disorders. The first one is somatic symptom disorder. The others are illness anxiety disorder, conversion disorder, factitious disorder, psychological conditions affecting other medical conditions is the last one. For today's presentation, I'm going to focus on the 4 of these 5 disorders. Factitious disorder, I'm not going to discuss factitious disorder because I think factitious disorder is so factitious disorder. I'm not going to discuss factitious disorder. For one thing, it's not very common. It seems to be a phenomenon that's somehow not very common, but definitely present in Western cultures. But in our country, it's a very rare occurrence. We hear about it once in a while, but I don't think it's worth spending our time on. But at the same time, like once we are done with the presentation, if anyone is interested in knowing more about any of the disorders, then I'll be very glad to talk about these conditions in more detail. Patients have one or more somatic symptoms that become all-consuming or lead to notable impairment in their day-to-day lives. And what's different these days about the criteria about somatic symptom disorder and related disorders is in the past, the requirement was there that the symptoms should not be medically explained. But with DSM-5, things have changed, and even if the symptoms are part of a medical problem, then if the person is having an all-consuming or notable impairments in their day-to-day lives, then we can make the diagnosis of somatic symptom disorder, conversion disorder, or the other disorders that we mentioned in the previous slide. So somatic symptom disorder, patients with SSD, they believe that they have some severe yet undetected disease, and evidence to the contrary does not persuade them otherwise. They're fixated on one or more somatic symptoms that they are convinced are evidence of illness. And convictions might persist despite negative laboratory results, the benign course of the alleged disease over time, and appropriate reassurance from physicians. At the same time, others may have genuine medical condition about which they develop excessive and unreasonable anxiety. So usually patients who present with somatic symptom disorder, this is a very common presentation. Even decades ago, when the first person to probably practice psychiatry in Ethiopia, his name is Yale. He's from the Netherlands. He did conduct some studies, I think at 12. And even in that study, what he found was that most of the people, or as a sizable portion of the people who present to the outpatient department actually had psychosomatic complaints. And I don't think things have changed much over the past, I don't know, probably 40 years. And in our outpatient departments, it's not new to see patients who present with unexplained or disproportionate symptoms. So these patients, usually what would happen is they would visit the hospitals very frequently. They would have this huge chart, and it would be, you're going to, when you review the chart, what you'll see is that they have been seen by so many physicians who came before you. They have had multiple investigations, sometimes even invasive investigations, and that nobody has found anything wrong with them. And what usually happens, unfortunately, is these people, they become kind of stigmatized. And everybody will tell you, everybody will shun them, nobody wants to see them. So avoid ያደርጋቸዋል. And the problem with that is they'll keep coming back because nobody is taking their time and trying to understand what is driving the symptomatology behind the presentation. These people will keep on coming and coming, and they'll keep on taking the time of health professionals, and they will keep, sharing precious resources. But these people are not doing this intentionally, and it is because they are really suffering that they would come again and again and again to health professionals. And sometimes these people could have some kind of medical problem. They might have a chronic illness, but they would present multiple times. They would present probably every week or every couple of weeks with a new complaint. And you try to understand the new complaint in the context of their existing problem. And sometimes that can be very frustrating because you think the underlying problem is well controlled and that the patient is doing well clinically. But when you check and when you try to see what's driving the new presentation, then you might have difficulty in finding a reason. In terms of, Hermon is telling me to speak up because the voice is too low. I'm trying to figure out what's going on. I'll try to speak up as loud as I could. In terms of etiology, the tendency to augment and amplify their somatic sensations, low thresholds for and low tolerance of physical discomfort can be the reasons behind the presentation for this population. So, for example, what ordinary people, what persons usually perceive as abdominal pressure, persons with somatic symptom disorder might experience as abdominal pain. They may focus on bodily sensations and also misinterpret them and become alarmed by them because of a faulty cognitive skill. So in terms of focusing on bodily sensations, all of us, if we really focus on what's going on in our body at any given moment, then we are bound to discover different sensations all over our body. And the more we pay attention to them, these sensations, they become amplified and they become augmented. And if our thinking is prone to misinterpretation, then we might look at them and think, oh, okay, oh my God, I'm having some kind of problem. I'm having a heart attack. I'm having cancer or something like that. So it seems to be a combination of tendency to augment and amplify somatic sensations, and the tendency to misinterpret these sensations because of faulty cognitive schemes. The other consideration in terms of etiology is the social learning model. So in every culture, when a person is sick, they are offered the sick role, and the sick role can be important because it could help the individual to avoid noxious obligations, to postpone unwelcome challenges, and to evade usual duties and obligations. And this could unintentionally encourage people to present with different problems and try to assume the sick role, especially with individuals who are very much disadvantaged and who do not have a voice in the community. Then probably being sick can be, or being seen as a sick person can be advantageous, because the sick role then would give the person a voice, and the person would have the opportunity to express their misgivings. They might ask for a differential treatment from their family and their community. So all these things might play a role, and we don't know exactly what causes psychosomatic disorder, but it seems to be a complex phenomenon that happens because of this tendency to augment and amplify somatic sensations, plus this misinterpretation because of faulty cognitive schemes. And on top of that, you can also consider the social learning model or the role of the sick role. Differential diagnosis, non-psychiatric medical conditions, including HIV/AIDS, endocrinopathies, myasthenia gravis, MS, degenerative disease of the nervous system, SLE, and occult neoplastic disorders might give a picture that could be very similar with somatic symptom disorder, because the presentation of a person with somatic symptom disorder is usually a number of symptoms distributed all over the body. So, a person would come to you and they would say, I have back pain, headache, and I have a problem breathing, and then I'm having some abdominal issues. When I walk, I'm feeling weak. So they can present with multiple symptoms, and those symptoms, they might be confusing, and they might look like presentation of other medical conditions that I mentioned before. Another differential. Okay, so let me, since I'm getting feedback that there might be some echoes, so let me try with the headphones and see if things change. So my apologies. Okay, apologies for the problem with audio. So I'm going to start from where I left off, unless people want me to go back a few slides. Okay, so I'm going to continue from where I left off. I was discussing somatic symptom disorders. The differentials include non-psychiatric medical conditions. Usually patients with somatic symptom disorders, they might have signs and symptoms from on different systems. So they might present with headache, they might present with back pain, abdominal discomfort, and changing GI habit, all those things. They could be present. They could be present in problems, and sometimes it can be confusing with patients who present with HIV/AIDS, endocrinopathies, myasthenia gravis, multiple sclerosis, and the other disorders that I've mentioned here. And it can mislead to a misdiagnosis. Sometimes people could be diagnosed as having somatoform disorder or medically unexplained symptom, and later on, 5-10 years later, they might be diagnosed with multiple sclerosis or another disorder. So this highlights the importance of paying attention to the history, the physical examination, as well as doing the necessary investigations. The other differential we can entertain is illness anxiety disorder. This is a disorder that was known as hypochondriasis. Probably most of us went to medical school before 2015. We used to know this disorder as hypochondriasis. And this is the differentiation is because the emphasis on illness anxiety disorder is on fear of having a disease rather than concern about many physical symptoms. So people presenting with illness anxiety disorder, they are very much focused on the fear of having a deadly disease. Conversion disorder it can be differentiated from somatic symptom disorder because it is acute and generally transient and usually involves a symptom rather than a particular disease. So patients with conversion disorder, they might present with motor symptoms or sensory symptoms or seizure-like presentation. It can be there as well, but usually the presentation is very acute and it resolves within few weeks in most individuals. So it is not difficult to differentiate conversion disorder from somatic symptom disorder. In terms of course, the course of the disorder is usually episodic. The episodes last from months to years with equally long quiescent periods. The presentation can start at any age, but for most people, the presentation starts after the age of 30. And it is usually episodic. It comes and it goes. And usually these episodes can be related with psychosocial stressors. So a person might come to your clinic and they might tell you that they're having this chronic problem with back pain that comes and goes regularly. And when you follow these patients over a long period of time, and if you are really observant and if you are taking a good history, what you usually discover is that the symptoms flare up when there is a psychosocial stressor in the person's life. So the person might tell you that whenever you see her and she's presenting with acute exacerbation of the back pain, and when you ask her, what has been happening in her life, then you might hear different stories. For example, she might be having marital problems with her husband. The next time she comes, it could be a problem with the neighbors. The next time she comes, it could be a problem with her mother-in-law. It goes on like that. So always when patients keep coming back with chronic symptoms, whether it is headache, back pain, or symptoms that look like irritable bowel syndrome, it's important to try and see if there is a psychosocial stressor that's going on in the background. think it's very, very important. In terms of the general approach in treatment, one of the most important things is building a therapeutic alliance based on respect for the patient's symptoms and acknowledgement of their validity. There is a huge problem, and not only in Ethiopia, probably also in other places. But in my experience in our setting, there is a huge problem with regards to the treatment of patients who present with somatic symptom disorder in general. And that problem is most people look at them and think that they are not having real problems, that they are just mooching from the healthcare system, that they are just wasting your time. So there is a lot of, unacknowledged and unspoken resentment against people, who come to our attention with this kind of problems. But the truth is, these people are suffering, and they are coming to the health center again and again. They're coming to a clinic again and again, not because they enjoy, the look and the smell of your office. It's usually because they're suffering, and it's very important to respect their presentation, to respect their problems, and to acknowledge their pain and the validity of their pain. Because in truth, when a person comes to you and she's complaining that she's having a headache, even if the headache is part of a psychosomatic presentation, it is a real headache. The person is suffering from a headache. So I think this is a very important consideration. And usually these people are very fine-tuned because they have been in and out of the health system. And they come to your office and they look at you, how you speak to them, how you treat them. And the first thing, unless you're showing them the respect that they deserve, what they would glean from that interaction is that you don't care, that you're not going to pay enough attention. And that kind of reinforces that person's belief that there is something wrong with them and that you are the wrong physician to diagnose it or to find it. And because patients lack this confidence in their healthcare providers, usually when we tell them that we found that there is nothing, in quotation, nothing wrong with them, they don't believe us. They think it's because of our incompetence. They think it's because we don't pay attention. So the cornerstone of treatment for patients presenting with somatic symptom disorder is respect for the patient and acknowledgement of the validity of their pain. The other important consideration in general approach in treatment is active receptive listening, which is very much underrated. We think listening is a very mundane skill, but it's not a mundane skill. It's something that needs practice. And the more you listen, the more you understand what the patient is saying. And sometimes in my interaction with patients, what I notice is, patients, they keep on telling you something again and again and again. And usually they do that because they think that you are missing something important, that you're not listening. So it's very important to go back and to hone in into that area that they want to talk about, even if it's outside of your interest, even if it's outside of your specialty. It is very important to go back and listen to the patient, because, in other words, by repeating those things, the patient is telling us, and he or she is saying to us, this is very important for me, and this is probably a telltale sign that it could be a very important point in terms of the evolution, the worsening of their presentation. We also need to be very careful not to be overly reassuring. Sometimes we might feel very sympathetic towards these people who are suffering, from chronic pain problem, or and as a presentation. And we can be overly reassuring. That's something we do, especially as junior practitioners. We tend to overly reassure our patients. They tell them that they will be okay, they will be fine. This is as bad as being dismissive, because in a way we are over-promising, and definitely we will be under-delivered, because somatic symptom disorders, they are notoriously difficult to treat. So we need to strike a balance between reassurance and between being overtly dismissive of their presentation and being confrontational. We need to be somewhat neutral. When I say neutral, I'm not saying we should be these automatons who don't try to understand what the patient is saying or just sitting there. It's about not being overly rational, but at the same time, not being dismissive. So we need to validate the patient's concerns and symptoms, but at the same time, we shouldn't commit and say, you're going to be okay, or we shouldn't tell them that it's all in their head or all in their mind. And something that I mentioned earlier on is that these patients present with this very big, fat medical charts, and it can be, how can I put it? It can be very discouraging when you see those huge charts. And you might make up your mind even before the patient comes to the room. You might be thinking, oh, this is a patient with quote unquote hysteria, or somebody who's malingering, and you might make up your mind before you even saw the patient. And it's very important to avoid this and to approach the patient with an open mind. And you might be surprised. I've had patients who have been on treatment for many, many years. And sometimes patients that I've seen for several years, and sometimes I discover things that are completely new that could change the patient's diagnosis as well as treatment. So open mind is also an important aspect or component of the general approach in treatment towards SSD. At this stage, we should avoid psychological questioning and interpretation. Probably this is something relevant to psychiatrists and psychologists, probably not as much to other health professionals. And just to reinforce what I've said in the previous slide, patients may perceive premature reassurance as disinterest or dismissiveness. And many patients do not really acknowledge or recognize emotional issues. And the more we press them, because of what we learn in medical school, that psychosomatic problems have emotional roots, and we should explore it. So usually we can be overzealous and try to push them to confront their emotional issues. And that can be very problematic, because patients with somatic symptom disorder, sometimes they present with bodily symptoms, because presenting with emotional symptoms is either unacceptable or not feasible in their situations. For a person who is living in rural Ethiopia, presenting with quote unquote low depression, anxiety, it can be seen as something, something unacceptable. But for a farmer to come to your outpatient department with back pain, with headache, with sore muscles, that's very much acceptable. So pushing our own understanding of the disorder can have deleterious effects. In terms of the management, a very concrete suggestion is to take a very detailed history. Usually, it might take multiple appointments, it might take 2 or 3 appointments, but when we take more history, what usually happens is our understanding of the patient's problem usually deepens, and the patient will have more confidence in our ability and in our desire to help them. So they would be more forthcoming. And at the very end, our understanding of the patient can be very much enriched. And that would give us that would put us at a better place to manage their problems. A thorough physical examination is also very, very important. When we start, our therapeutic goals should be modest and limited to small attainable gains, such as a decrease in medical visits. For example, if this 50-year-old lady is coming to your clinic every week, probably making it, once every couple of weeks is a good goal. The commitment to single physician, because patients with somatic symptom disorders, they are notoriously known for their doctor shopping. So they would go from one clinic to another, to another, to another. And this is because they're thinking, this physician, he missed it. I have such a severe, such a difficult problem that all these doctors are missing. So the more they are told that there is no problem with them, the more they are convinced that it is because their problem is very severe, very occult, and very difficult even for well-educated physicians to detect. So they engage in doctor shopping. So if we are able to convince our patients to stick with a single physician, whether it's us or their primary healthcare provider, that is a very good achievement. The avoidance of unnecessary tests and procedures is another goal that can be achieved. Patients with SSD, they spend a lot of money, they spend a lot of time on tests and procedures. So, they might come from very remote places to have this, to have biopsies, to have MRI, to have CT scans, and so on. So if we are able to convince our patients not to engage in such exercises, then that is a very, very good beginning. So when we start with the treatment of patients like this, it's very important to focus on modest, small, attainable goals. As a physician, or you as a physician, should prepare for a long-term commitment to these patients, because usually they don't get cured within 6 weeks or 6 months or something like that. So for the duration of your stay there, most probably these patients will keep on coming back again and again. But what could work in your favor is if she was coming every week, and then by the end of your stay there, if she's coming once every 2 months, then that's a huge achievement. And what this tells you is that you are enabling the person to live with her back pain or with her headache without your reassurance for 2 months instead of 1 week. That's a big thing. That's a huge achievement. Limiting specialist consultation unless there is evidence of comorbid physical conditions. When they come, if we send our patients to the GI specialist, when they come with abdominal complaints, to a neurologist when they come with headache and back pain, then that is very problematic. So we should be able to, especially as general practitioners, and also as a health professionals who practice in primary health care, it's important to be able to contain these patients in that setting instead of sending them to specialists and wasting the time of the specialist as well as the money and the time of the patient. Recommendations for exercise, yoga and relaxation, meditation. I know these things sound fancy, but whenever possible, it would be a good idea if we can recommend exercise, relaxation, and meditation, because usually they are much more acceptable by patients than psychological treatments. and even medications. Consultation letter is a way of treating somatic symptom disorders that has been tried in the West. What happens is they put primary health care physicians, they pair them with psychiatrists, and there will be ongoing conversation through a consultation letter between the primary health care provider or the family physician, as we call them, and the psychiatrist. So the psychiatrist would see the patient with SSD and would send back a consultation letter detailing, detailing his findings and also giving recommendations to the primary health care physician to avoid unnecessary diagnostic procedures, invasive treatments, and hospitalizations. Psychotherapy, if and when available, can be or is the first line of treatment for patients with somatic symptom disorder. In our country, it might be difficult for patients to access psychotherapy, but things might change in the future. And in Addis, I think people are already, things are already in the process of changing, and it might be possible for people to find psychotherapy. The type of psychotherapy that's helpful for SSD is CBT or CBT type interventions. And these interventions appear to help patients by modifying thoughts and behaviors associated with somatization. So CBT, for those of you who are not familiar with it, is cognitive behavioral therapy. So it has got a cognitive component as well as a behavioral component. So the behavioral component can include relaxation training and graded increases in activities. So relaxation trainings, it could be breathing exercise, it could be progressive muscle relaxation. And these things, they might sound a bit sophisticated, but in truth, these are very simple interventions. And anyone who is interested, you can go to YouTube and search using this. If you search for relaxation techniques using the terms relaxation technique, breathing exercises, or progressive muscle relaxation, then you can find very good resources that you can use for yourself and you can adapt for use by your patients. That is from a behavioral perspective. From a cognitive perspective, CBT helps patients to identify thoughts that contribute to increased stress, inactivity, and health concerns. One of the most important maladaptive thought patterns that we see in patients with SSD is catastrophization. So patients would take some sort of pain in some part of their body, and they would keep on obsessing about it. They would keep on ruminating about it, and this would lead to catastrophization. They would start thinking, "Oh my God, this is a symptom of cancer, or this is a symptom of HIV/AIDS. What's going to happen to my family?" So they go down this rabbit hole, which is never ending. And that leads not only to their presentation, but also makes them very anxious and also very, in some cases, it might also lead to low mood and depression. On top of CBT type interventions, brief psychodynamic therapy is also very helpful for unexplained somatic symptoms. Medications. So there is always a tendency to go for medications over psychotherapy or other behavioral interventions. But unfortunately for SSD, medications are of little value, and we should avoid medications when treating patients with somatic disorder, except in the presence of clearly delineated anxious, depressive, or psychotic symptoms. Sometimes we see a practice of prescribing certain medications, such as multivitamins, to treat patients with SSD. This is very bad practice, honestly speaking, because what would happen is the medication, obviously, it can help at the beginning because of the placebo effect, but it's not going to be very helpful in the long run. And it reinforces the patient's conviction that the problem they have is very severe and that it's not responding to medications that are being prescribed by these wonderful physicians, right? So please avoid any such practices. We think we are doing something good to our patients, but it's a great disservice to them in reality. So I've been talking about SSD for quite a while now. It's because it is the quintessential psychosomatic disorder. When we discuss the other disorders, most of what we say is going to be in relation with somatic symptom disorder. So, having a more detailed discussion on SSD was ideal. The next disorder that I would like to talk a little about is illness anxiety disorder, or hypochondriasis as it was known in the past. Patients with illness anxiety disorder, they believe that they have a serious but undiagnosed disease despite evidence to the contrary. So some patients, they come to you and tell you that, for example, I have patients come to me and tell me that they have brain tumor. Even if, then, your first reaction is that you're shocked and you're thinking, okay, how do they know? And they'll tell you, I've been to many physicians and they have done so many investigations, and the investigations are turning out negative, but I know that I have brain tumor. So the disorder, the problems they come up with can be AIDS, it can be multiple sclerosis, or usually it's some kind of malignancy. They may maintain a belief that they have a particular disease, or as time progresses, they may transfer their belief to another disease. So this is not unusual. They might start with one disease, and over time, it might change, or the belief might be transferred to another disease. Their conviction persists despite negative laboratory results, the benign course of the alleged disease over time, and appropriate assurance from physicians. What would happen is, for example, if a patient comes to you and they are very, very anxious that they have, let's say, HIV/AIDS, and then, you listen to their story, you take a very detailed history, you do physical examination, and because of their fear, you might order a lab investigation. When the lab investigation comes back negative, usually the first reaction of the patient is that of relief. So they'll be very relieved, they'll feel good, they'll feel very happy, they'll go home. But the problem is, it is usually a very short-lived relief. And after a week or a month or a couple of months, the person would come back, either with the same conviction, with the same fear, or with a different anxiety about a different illness. Their preoccupation with illness usually interferes with their interactions with family, friends, and co-workers. They are often addicted to internet search about their feared illness, inferring the worst from information or misinformation they find there. This nowadays, especially, this is a big problem for anyone who deals with patients who present with illness anxiety disorder, because patients, what they do is when they have anxiety about certain illness, symptom in their body, they would go to Google, they would search, they would search, they would say swelling on my neck or something like that, and the internet would give them lots of information and misinformation, or especially misinformation. And usually because of the cognitive the maladaptive thinking, what they would focus on is the negative things. They would focus on the more horrifying diagnosis, the more difficult diagnosis. So they would keep on reading and reading about the different possibilities and gradually focus more and more on the one that's most deadly. And afterwards, they'll start thinking and acting as if that is the truth, as if the swelling on their neck is actually because of thyroid cancer or something like that. And they can be very anxious, they can be very depressed. So this is one thing that has been coming up again, especially in this day and age. And one of the first things you could do, and probably should do, is try to work out a way for them to stop, if possible to stop, not possible to decrease their Googling of possible symptoms and possible diagnoses. Unlike somatic symptom disorder, however, these individuals do not have significant physical symptoms. So it's not about the physical symptom, it's more about the fear of having a specific deadly disease. So etiology, it's very difficult to know why a certain person developed this kind of presentation, but their childhood, their upbringing, what they have learned from the society in terms of social learning, model, the synchron, all these things might contribute. And another contribution could be, biological predisposition as well. The course is very similar to that of SST. It is usually episodic, and the episodes last from months to years with equally long present periods. And there is usually an exacerbation of somatic symptoms and psychosocial stressors. So if a person, it is usually the presentation we see is people present with exacerbation of their illness anxiety while they're having severe psychosocial stressors. So when they're having problems at home or difficulties at work or in their relationship, then they might present with illness anxiety. And if we are overly focused on the illness anxiety part, we might miss this interpersonal component of their problem. And usually, having discussion about the psychosocial stresses that are driving these problems can be a huge help, and it might actually help the individual in terms of getting better from their illness anxiety, even if it's not cured. Differential diagnosis, as you'd expect, other medical conditions, SSD, conversion disorder, OCD, engagement disorders. All these can be a differential diagnosis for illness anxiety disorder. In terms of management principles and treatment, the general approach that I discussed for SSD also applies for illness anxiety disorder. In terms of treatment, various group individual therapies, including CBT and psychodynamic psychotherapy, mindfulness training, exposure therapy, acceptance and commitment therapy, all these are found to be helpful to one extent or another in the treatment of illness anxiety disorder. For medications, there is only limited data. And the data concerns fluoxetine. So there is some data showing that fluoxetine can be helpful, but it's not a very robust finding. So the first line of treatment is psychotherapy. In the general approach, even if we are unable to do any kind of psychotherapy for our patients, the general approach that we discussed, such as validating a person's presentation, listening to them, following them up for over a long period of time. Those general principles can be very, very helpful. The next disorder that I would like to discuss is conversion disorders. So conversion reaction is acute in temporary loss or alteration in motor or sensory function that requires substantial discordance between the symptom displayed and any neurologic condition. So patients might present with motor symptoms or sensory symptoms, but the thing is, when you take a very good detailed history, when you do very detailed physical examination, then you'll find out that they don't align with known neurological conditions. And that is the first telltale sign that the person might be suffering from conversion disorders. In the past, conversion disorders were known as hysteria. And I remember when I was in medical school, how people used to look down or look at patients presenting with quote unquote hysteria. So, if a person tells you that, so that patient on this bed is hysteric, then that's the code word for just ignore them, and I hope things have changed over the years, but my gut feeling is that probably they have. And usually these presentations are often preceded by conflicts or other stressors. And one thing that we need to understand, and probably the thing that drives that content towards people presenting with conversion symptoms, quote unquote, hysteric symptoms, is there is this misunderstanding that these patients feign or just manufacture these symptoms, but that's not true. The symptoms and the deficits are not produced intentionally. These patients are not coming to your OPD with paralysis of the left leg or blindness just because they want to. It's not as if they can will these symptoms into existence. It's an unconscious process, and the patient has no power whatsoever over these presentations. So one possible presentation, sensory symptoms. So patients can present with anesthesia, paresthesia, but usually when you look at the distribution of their symptoms, it's usually consistent with either central or peripheral neurologic disease. It can also involve organs of special sense and can produce deafness, blindness, and tunnel vision. I remember one particular patient that I saw many years back who presented with blindness, and it was in the context of her finding out that the person she was having affairs with was also married, and she accidentally saw him with his wife, and over the coming days she developed blindness. And when she went to the ophthalmologist, there was no problem with her eyes, with her vision, so then she was sent to a psychiatric clinic. So patients can present with deafness as well, with inability to speak, aphonia, tunnel vision. All these things are quite common. Motor symptoms can include abnormal movement, gait disturbance, paralysis, weakness, and gross rhythmical tremors, coliform movement, tics can be motor presentations of conversion disorder. The movements generally worsen when calling attention. So when you pay attention to them, the movements usually worsen. And when you distract the patient, usually the symptoms might either lessen or go away. And there are lots of procedures, number of procedures that you can do, number of physical examinations and manipulations you can do in order to differentiate between, conversion disorder and, quote unquote, genuine neurological presentations. And so I'm not going to focus on those today, but if you are interested, you can always go to the text, and there are wonderful chapters about those ways of differentiating between these two problems. Seizure symptoms. I'm sure people are very familiar with this, especially as general practitioners, or if you are working in the medical OPD, you're going to see lots of patients with, in the past we used to call it pseudo seizure, but nowadays we call it non-epileptic seizure disorder. And patients present with seizure-like symptoms. And the pitfall here is some patients with an epileptic seizure also have a coexisting epileptic disorder. The one, we look at a certain group of symptoms to try and see if it is a real seizure or a non-epileptic seizure. And this group includes tongue biting, urinary incontinence, and injuries after falling. So if these things are present together or separately, usually our thinking is that that the person is having a real seizure disorder. But it's unusual, even if they are also, they can be present, but it's very unusual for people with an epileptic seizure to present with tongue biting and urinary incontinence. Other associated features, they can have primary gain. Patients, achieve primary gain by keeping internal conflicts outside of their awareness. Secondary gain is they can have, they might be looking for some tangible advantage and benefit as a result of being sick. Labile indifference is, the translation is beautiful indifference. It's about patients with conversion disorder. They present with very little concern. If the expectation is that the person, if they are paralyzed, that they would be in a great deal of anxiety. But if their presentation is because of conversion disorder, usually, not always, but usually, the person might look and sound nonchalant. Identification is something that we see from time to time. These are people who unconsciously model their symptoms of those of someone important to them. So I had a patient who presented with difficulty swallowing after somebody close to them died because of esophageal C. Differential diagnosis, other medical conditions are very important differentials. I want people to take a very good look at the next two lines, especially the second one, which says 25 to 50% of patients classified as having conversion disorder eventually receive diagnosis of neurologic or psychiatric medical disorders. So apparently what happens is these people, these researchers made this longitudinal study, and what they found out is people who were labeled as having conversion disorder at some point in their lives, and followed by these researchers for many, many years, 25 to 50% of them actually developed actual neurologic or non-psychiatric medical disorders. So this is concerning, because there is a huge possibility that these patients that we see at our OPDs that we diagnose as having quote unquote hysteria, the hysterics, probably we're missing lots of patients who could have been actually suffering from real or genuine neurologic and psychiatric problems. The other differential is somatic symptom disorder, but for somatic symptom disorder, inconsistency with neurologic disorders is not required. In terms of course, it's usually very acute, but crescendo of symptomatology may also occur. Symptoms or deficits are usually of short-term duration, and approximately 95% of acute cases will meet spontaneously within 2 weeks. So it's usually an acute disorder, but unfortunately, there is also a possibility that patients might develop a chronic subtype of conversion disorder, which is the diagnosis made if the symptoms persist after 6 months. The risk of recurrence is also significant. 1/5 to 1/4 of people might present with a recurrence within 1 year of the first episode. Management principles and treatment, it's important, as I mentioned before, building therapeutic lines, listening, tolerance for repetition, neutral approach, open mind. All those things we discussed for SSD also hold for conversion disorder. Later on, in the hands of a person who is well versed in psychotherapy, social psychotherapy, interpretations and explanations might work, but usually not in the early days. Reassurance may be helpful. Any implication to the patient that he or she is malingering is very counterproductive. Careful attention to any history of trauma, sexual abuse, physical abuse, family history of conversion symptoms are also very important. And neurologic workup, obviously, of suspected conversion disorder, including, routine lab investigations, imaging is also recommended. Behavioral interventions should focus on improving self-esteem, the capacity for emotional expression and assertiveness, and the ability to communicate comfortably with others. So, just to make it very simple, for a person presenting with conversion disorder, the way we think of it, not for all of them, but at least for some of them, they are speaking through their body. For example, the person who lost her sight after seeing that the person she was dating was also a married person. What she's saying is, I don't want to see this. I would rather go blind. Or a person presenting with a person, let's say, are being transferred from one city to another if they develop paralysis. What they're saying is, I don't know what I don't want to go. I don't want to go there. So unless we pay attention to the history, unless we have good rapport and a good conversation with these people, then the possibility is that we will never find out what the person is saying through their symptoms. So understanding what the person is saying through their symptoms and reassuring them, telling them that it's not a deadly disease or that they are not going to be paralyzed forever. These things are very important. So as a whole, the aim is to enable people to speak using words instead of symptoms and their body parts. With chronic conversion disorder, muscle contractures can occur. Physical therapy is very important when that happens. Once chronicity has developed, intensive treatment may use all treatment modalities, including inpatient treatment. So I'm left with psychological factors affecting other medical conditions. But in the interest of time, I'm going to stop here because we're left only with 30 minutes. And many of you have many important questions. So thank you for listening. And I'm going to stop here and hand the floor back to Dr. Herman.
Thank you, Dr. Benyam. It was a really nice presentation. So we have a lot of questions, but before we proceed to questions and answers, we will just, we can share a link on the chat box to everyone. እና ሁሉም ሰው ሬጅስተር አድርጎ ጥያቄዎቹን እንዲመልስ 2 ደቂቃ እንሰጣለን። በዛውም ዶክተር ቢኒያም ትንሽ አረፍ ለማለት ውሃ ለመጠጣት ጊዜ እንሰጣለን።
Thank you.
እሺ I will be sharing, give me a moment, I'll be sharing the link. If you have more questions, አሁንም ቢሆን ቻት ቦክሱ ላይ መጨመር ይቻላል or ደግሞ እጃችሁን እያነሳችሁ ዳይሬክትሊ መጠየቅም ይቻላል። I think የሌላውንም ሰዓት ለመቆጠብ በመሃል ያልሞላችሁ እየሞላችሁ ጥያቄዎቹን አንዳንድ ሬዝ የተደረጉትን ጥያቄዎች እስከዛ ዶክተር ቢኒያም ይመልስልናል። ዶክተር ቢኒያም አለ?
አለ ያርሙን
እሺ
ቪዲዮ ኦን ለማድረግ እየሞከርኩ ነበረ።
ኦኬ
ከተቻለ ኦን
I think የመጀመሪያው ጥያቄ ከአለባቸውና ናትናኤል ተመሳሳይ ጥያቄዎች ተጠይቀው ነበርና is it curable የሚል ጥያቄ ነው።
ጥሩ ጥያቄ ነው። one third curable ሊሆን ይችላል። curable in a sense ሰዎቹ ሲምፕተም ፍሪ ሆነው ሊኖሩ ይችላል። ያው ያንን ይሄንን ስንል በትሪትመንት ደግሞ ተገቢውን ትሪትመንት ካገኙ ሰዎች ኪውርድ የሚሆኑበት እንትን አለ አጋጣሚ አለ። ስለዚህ ዋን ሰርድ አካባቢ ያሉት ሰዎች ኪውርድ ሊሆኑ ይችላሉ ብለን እናያዘው። ነገር ግን what we have to keep in mind is even if people are not cured, then to enable them to live with the disorder, at a much better level of functioning is also very good thing. So we shouldn't despair even if we are unable to cure all of the patients with SSD that we see.
ሜቢ ከዛ ጋር ተያይዞ ሳይኮቴራፒ ምን ያህል ኤፌክቲቭ ነው የሚል ጥያቄ አለ እና ተመሳሳይ ጥያቄዎችን ግሩፕ ለማድረግ ሲቢቲ እና ሴትአፕ ላይ ይሰራል ወይ? ምን ያህል ሲቢቲስ ኢፌክቲቭ ነው ወይስ ግሩፕ ቴራፒ ይሻላል? አሁን ደግሞ ቻት ቦክስ ላይ ድጋሚ ተጨማሪ የመጣው አሚትሪፕትሊን ፕሬስክራይብ ማድረግ እንችላለን ወይ የሚሉ ጥያቄዎች አሉ ከትሪትመንት ጋር ተያይዘው።
Yeah, so psychotherapy is the first line of treatment for all of them. Whether it is conversion disorder, SSD, anxiety, for all of them. Psychotherapy is the first line of treatment. If we are unable to do, when we are unable to get patients to have a psychotherapy, we might consider medications, but the evidence is not very strong. Probably except for SSD, there is some evidence, especially for the older antidepressant medications, such as tricyclic antidepressants, which includes amitriptyline. So for amitriptyline, there is some evidence, but usually the advice is for people to avoid any medication as much as possible. But if we are very desperate and if the patients are not responding to any of our treatments, then probably antidepressants such as amitriptyline can be considered for illness anxiety disorder because of the anxiety component. There are some researches that show that SSRIs, especially clozapine, can be helpful. So that's, I think, as far as medications are concerned, there is very, very limited evidence, but those are the two medications, from my review of the literature that I found could be useful, at least for some patients. In terms of psychotherapy, yes, CBT is very effective, or at least it is the most effective therapeutic modality that we have for somatoform disorders. Other psychotherapeutic modalities, such as brief, intensive, short-term psychodynamic psychotherapy, can also be very helpful. But I think there are not many people who can do brief dynamic psychodynamic psychotherapy in our setting. In terms of CBT, there are professionals who can do CBT. So, for example, psychiatrists can do CBT, clinical psychologists. We have a very vibrant clinical psychology program at the Department of Psychiatry at AAU. So, clinical psychologists, psychiatrists can do CBT. And also other professionals, if they have the opportunity to do CBT, it's not necessarily limited to psychiatrists and psychologists, other professionals as well, if they are interested, and if they have the opportunity to get trainings on CBT, they can also probably provide the service. But it is available, especially in Addis, it's available, but also in other cities, in the other regions, they are also available. So you can inquire and see if there are any psychiatrists and psychologists, clinical psychologists in your area. And if you find some of them, then they might be able to do CBT.
Thank you. ከትሪትመንቱ ብዙ ሳንወጣ ሌላ ጥያቄ ያለው is there a place for neuromodulation, electroconvulsive therapy እና transcranial magnetic stimulation for conversion disorder የሚል ጥያቄ አለ. How do you see that question?
Neuromodulation, definitely. I mean, neurofeedback as a whole, biofeedback, neurofeedback, they can be helpful. They can be helpful in conversion disorder, especially if you are facing a patient who is having chronic conversion disorder. Then you have the permission to do whatever you think is going to help the patient, right? So neuromodulation, technically, there is some evidence. Not a lot of evidence, but there is some encouraging evidence. In terms of transmagnetic stimulation, I haven't seen that. Probably, I mean, I haven't looked into the literature, but it's possible. I mean, TMS, I've seen, from my experience, I've seen people benefit from TMS. Patients with treatment-resistant depression and anxiety, I've seen that they might benefit from transcranial magnetic stimulation. So I don't see any reason why it wouldn't work with conversion disorder, but I haven't seen any research. But maybe probably it's something that we should look into. The third option was the ECT, electroconvulsive therapy. I don't think I would go for ECT, because ECT is a very effective and I would say very safe intervention for severe problems such as severe depression, catatonia, patients presenting with bipolar disorder, schizophrenia, who are not responding to medications. But for conversion disorder, I don't know, I'd be very reluctant to consider ECT because there are some side effects, including cognitive side effects. So I would think twice before I think of ECT. So I wouldn't go for ECT. I would rather go with psychotherapy and probably some medications. That's it. Thank you.
Okay, thank you. So another interesting question raised የተደረገው multiple times was what's the role of spiritual treatment in somatic symptom disorders እና help ያደርጋሉ ወይ በሚለው አንግል ዶክተር ተስፋነሽ አንስታ ነበር። Another question ደግሞ ያለው how do we navigate somatic represented or conversion symptoms ከreligious ዶግማዎች ላይክ አሁን እንደ ቡዳ ተብሎ ነው የሚደረገው ጋር እና ሁለቱ ጋር ተያይዞ ስፒሪቹዋሊቲ እና ሶማቲክ ሲምፕተም ዲስኦርደር ጋር ትንሽ አያይዘህ ብታወራለን አዝ ትሪትመንት እና ደግሞ በሁለተኛው ሳይድ።
I'm not sure about the second question. I'll come back to it and maybe explain it to me. For the first one, with regards to the efficacy of holy water in the treatment of SSD, right? That's the question.
Yes, spiritual
So, the place.
help ያደርጋሉ ወይ?
Okay. In order to say something is helpful or not, then you need to have you need to do some kind of systematic research and try to see whether that intervention helps in comparison with treatment as usual or with other treatment modalities. So this question I don't think can be answered, unless we go ahead and do some kind of research. Then it will be very difficult to say in general whether traditional, cultural, spiritual interventions are helpful or not. But this is not to say that they're not helpful, and this is not to say that we discourage patients from engaging in such practices. Usually, what we recommend is, if the patient thinks that something or some intervention, whether it's cultural or spiritual, if they think it's helpful, we're not against that. It's up to the patient to choose what benefits or what is going to be helpful for them. So we don't tell them not to do this or that. The only caveat that we put there is that we don't encourage them to discontinue their medications, or their therapy. So as long as they continue therapy and medications, people they are free, obviously, to pursue any kind of treatment they think is helpful. Anecdotally, you sometimes find people who benefit from spiritual or cultural interventions, but those are anecdotal evidences. But in terms of recommendations in order to say whether something works or not, then you have to do research. Not only one or two research, but you have to do many research repeatedly and see if there is a significant effect there. So I'm not sure if I answered the question, but those are the thoughts that came to my mind.
Yeah. So the other side of the question የነበረው እንዴት ነው somatic symptom disorders, especially conversion, እንደ ቡዳ or spiritual meaning ሊሰጣቸው ይችላል እና how do we navigate that የሚለው ጥያቄ ነው እና ከሱ ጋር ምናልባት ተመሳሳይ ጥያቄ አንድ ላይ ለማድረግ dissociative disorders, are they considered as somatic disorders እና እንዴት ነው ማኔጅ የሚደረጉት የሚልም ጥያቄ ነበረ።
Okay. So, it all depends on the patient's explanatory model. So when you see patients, one of the first things you should do is you should try to explore their explanatory model in order to, so just to briefly talk a bit about explanatory models. Explanatory models are the patient's understanding about the cause of their illness as well as the remedy to their illness. So if it is a spiritual explanatory model, usually it could go along the line of I'm sick because of evil spirit. I'm sick because of curses. I'm sick because of my sins, and usually the solution would go along with that. So the solution that people would come up with, like if I repent, if I go to a church or mosque, if I go to religious leaders, and if I tell them, if I share my problems with them, or they might say, if I go to holy water place. So people can have their own explanatory models in terms of what's causing their problems, why it is happening at that point in their lives, and what they should do or they could do in order to get better from that illness. They have their own explanatory models. And as physicians, as psychiatrists, this is something that we do on most occasions. But even as physicians, it could be very important to inquire after the explanatory model of the person. Because sometimes what would happen is we have our own explanatory model, which is the biomedical model. And based on that, we might prescribe some medications. And the person would come back next time and will tell us, I haven't taken that medication. So let's say this is a person with hypertension, and you prescribe hypertensive medications. The next time you see them, they tell you they are not taking their medications and the hypertension is not controlled. Usually, our reaction, our reflex is to confront the patient and to tell them, you should do this, you should do that. Unless you do this, you die, something like that. But usually, this kind of interventions, the confrontation, this paternalistic approach, usually it fails because people's conviction about their spirituality is much stronger than their belief in the biomedical model or in our competence. So we need to explore why that particular person is declining to take the medication. What is rationality? After we find why that person is not taking his medication or doesn't want to engage in physical activities or change their lifestyle, then we can, with the patient, in collaboration with the patient, we can come up with a solution. So the first step should be exploring the explanatory model, and the next step would be to work with the patient in collaboration. Sometimes what I would do is I'd sit with the patient and say, okay, so my understanding of the problem is different because I'm a physician. My model is a biomedical model. And your model is different. It's a very spiritual model. I can't say your model is wrong and my model is right. What we can do is we can have a discussion. So I ask them to have a discussion, ask them, I say to them, so what's the solution? What should we do? So you kind of bring the problem into the room and share it with the patient. And usually the patient would help you come up with a solution. But if we keep on hammering and telling the person to take his medication, that you die and so on and so forth, usually that could be a very fruitless endeavor. With regards to, so for example, if the person thinks that if their explanatory model is that their hands are paralyzed because of Buddha, then it's no use, arguing with them and telling them that it's the conversion disorder. So, probably the best outcome of the discussion between the two of you would be for the patient to go and try different interventions that they believe are going to help them with their problem, and for you to leave the door open so that the person can come back. You have to help your patient save face if it fails, if the intervention fails, and if you are telling them you are wrong and so on and so forth, then they're not going to come back. But if you are receptive and validating their concerns, then there is a bigger or better probability that they will come back and get a better treatment from you. So not closing the door is important. About dissociative disorders, it's a whole whole huge topic. So I'm not going to start talking about dissociative disorder. So I don't know if Yetenaweg and Ima, if they decide to have a session on dissociative, maybe we can talk about it there. Thank you.
Okay, thank you. በደንብ ኢላቦሬት ነው እንዲያውም ያደረግከው ካሰብነው በላይ ሜቢ ትንሽ ወጣ ያለ ፖይንት ሶሻል ሚዲያ ስፔሻሊ ዊዝ ኢልነስ አንግዛይቲ ሃው ዱ ዩ ሲ ኢት ዘ ዩዝ ኦፍ ሶሻል ሚዲያ እና ያው ጉግልም ያው ቴክኖሎጂ
it's a big problem. It's a problem that we see, that we read about it, but we also see it in our consultation offices. Like in our office, we see patients who would go on the internet and Google about their quote-unquote conditions. They go on Reddit, and other websites where they ask about their conditions and have conversation with other people who also might have problems similar to them. So like, it's not something inherently bad. I'm not saying social media is bad, or I'm not saying people going on social media and other platforms to find out about their problems, to discuss their problems, is a bad thing. I'm not saying that. But the problem is the kind of information they get from social media platforms, and Google and Reddit and Twitter and so on. It's not well calibrated. People write all sorts of stuff. People write things based on their experience, based on their understanding, and there is no way of knowing which information is a valid information. So it can be a very dangerous place to go to, seeking information. So what I would suggest is, sometimes I try to reason with my patients, and they might decide that going on Reddit or Google is not a good thing, and they might say, I'm not going to do it anymore, and they might be able to stick with it. Sometimes they might not be able to do it, or they might not be willing to. They might tell you, my community on Reddit or on Twitter is very important to me. I don't want to let go of it. I want to be part of that community. And when that happens, what I suggest we do is accept the patient's decision, but at the same time, try to come up with some set of ground rules that would help them, we know what's the good from the bad. So, you can help them differentiate, the good information versus, quote unquote, the bad information or the misinformation. So it's not a very straightforward problem, but it's a big concept, and it is something that should be discussed with the patient, and it's something we should come up with a joint solutions to.
So I'm trying to address as many questions as possible now. Group እያደረኩኝ ነው ያለሁት. So one question was somatic symptom disorder ከማሊንገሪንግ እንዴት እንለየዋለን የሚል ጥያቄ ነበረ. And another one is factitious disorder እና ማሊንገሪንግን እንዴት ልንለያቸው እንችላለን ነው. So maybe
Okay.
how to differentiate all of these.
Sure. So malingering. So let me go back to the two concepts that I briefly discussed in the presentation: primary gain and secondary gain. Primary gain is when the gain is somehow psychological. For example, with the sickle, people, no, not the sickle problem. That's not a good example. But when the primary benefit is psychological, I don't want to elaborate because I don't want to get into the details of psychodynamics. But let's put it like that. And there is the secondary gain. Secondary gain is when the gain is something tangible and in the external world. So if somebody gets money out of their diagnosis, if somebody gets, for example, say exemption from military service, exemption from all sorts of assignments, those are secondary gains. So that is the most important thing. So if the patient comes to you, if they are looking for a sick leave certificate, a board certificate, exemption from military service, exemption from being sent to the regions, and so on, it's always very important to keep an open eye and pay attention. So I'm not saying everybody that asks for a board is malignant. Obviously not. Most of the people, probably 95% of the people presenting looking for a board certificate are usually people with real problems. But it's something that you have to keep at the back of your mind. Whenever you make diagnosis, and if the patient is going to get some kind of benefit from your diagnosis, the possibility that they could be malingering is there. But it's not our go-to diagnosis, especially as psychiatrists, because we like our tendency is to believe our patients and try to help them to the best of our abilities. But that doesn't mean that we just accept anyone who claims that they have this disorder and that disorder. And some of the things we do is, for example, we evaluate patients again and again, probably before a person is considered for a board. Probably we see them for 6 months or a year. So how many, usually not many people are interested in spending 6 months or a year in psychiatric follow-up treatment just to get a board. So that's one disincentive, and the other is when you see a person again and again and again, if there is an inconsistency that you notice consistently, then the suspicion is that they might be malingering. With factitious disorder, these are patients who produce symptoms in themselves or in their children or in other people. When it is on other people, we call it infectious disorder by proxy. These are people with serious psychological issues, and they are doing those things not to get any external benefits. For example, the person who is, making sure that her wound doesn't heal by, putting different things that are going to make sure that it doesn't heal, is not doing it to get money or to get exemption. But, people with such disorder, they do these things because they think they need the attention from medical professionals. And it is usually can be a very deep psychological problem that's driving them to look for such attention. And it usually happens in people who have had serious medical issues as children, who have had experience with different procedures and interventions. And because of the psychological repercussions of what happened back then, people might come back again and again to seek that relationship with the health system. So basically, it's as if these individuals have developed some kind of relationship with the medical system, and they want to be in the medical system and get the attention of the medical system. But it's not about secondary gains. So that's the differentiation between factitious disorder versus malingering. But if there is no cause to think that the person is looking after primary or secondary gains, then the consideration is that they might be suffering from psychosomatic disorders. Not sure if I'm making sense, but that's the best I can do. Apologies.
ኦኬ ቴንክ ዩ ዶክተር ቢኒያም ምናልባት ቪዲዮንም ኦን ብታደርግልን ለመጨረሻ አንድ ሁለት ጥያቄዎች so another set of questions is ሁሉንም other medical conditions rule out ማድረግ ይጠበቅብናል before diagnosing somatic symptom disorders የሚል ጥያቄ ነበር followed by በቂ ኢንቨስቲጌሽን ሞዳሊቲስ በሌሉበት ሀገር ወይም ሪሶርስ ሊሚትድ በሆነበት ሀገር for sure እንዴት ነው አንድን ሰው somatic symptom disorder ነው ያለው ብለን ሌብል የምናደርገው የሚል ጥያቄ አለ። ተያይዞ ደግሞ እንዴት ኤክስፕሌን እናደርገዋለን that their pain is related to ይሄ like their feeling እና አሁን ለምሳሌ somatic symptom disorder ብለን ዳያግኖስ ካደረግን በኋላ እንዴት ኮሚዩኒኬት እናደርጋለን የሚል ኤግዛምፕል ወይ how you approach that patient ትንሽ ብትነግረን እንዴት አድረስ ማድረግ ወይ እንዴት ኮሚዩኒኬት ማድረግ እንችላለን?
Sure. So about the need for investigations to rule out other medical conditions, it's something unavoidable. If a person presents with, let's say, seizure-like symptoms, then as much as possible, we need to do our due diligence and take a very detailed history, then do a very detailed physical examination, and then, if possible, do EEG and other investigations if they are needed. So that is ideally what we should do. It's not about ruling out everything, right? I don't think that's even a possibility. But we need to be pragmatic. We need to be pragmatic and say, of course, you're not going to do, I don't know. You might need MRI if you think the seizure is emanating from space occupying lesion or something, but you don't do MRI for every patient with seizure disorder, right? So we need to be pragmatic. And we don't need to rule out every disorder, is it even possible, right? So what we need to do is we need to pick our battles and try to be very pragmatic and try to rule out the most likely differentials. But once we're done with the most likely differentials, if the likelihood that somatic symptom disorder is the diagnosis, then we can put it as a working diagnosis and work with the patient as somatic symptom disorder. Because we always practice medicine, under the constraint that we are in. So, it's never enough. We are never able to rule out, we will never be able to rule out everything, right? So it's about being pragmatic. It's about picking our battles. It's about focusing on the most likely differentials and trying to rule them out. And then, if it looks like it is SSD, then we stick with that. The other thing is, with regards to investigations being available in the regions, Ethiopia, and other places, my take on that would be most of the information, at the end of the day, most of the information that is going to be very crucial in terms of making the diagnosis comes from our history taking and our physical examination. And, if you do a very thorough physical examination, if you take a very thorough history, then probably you have a very good amount of information in your hand that you can use to make a decision with regards to diagnosis and management. For example, with neurological disorders, even if the person is presenting with, let's say, hemiparesis, there are so many things that you can do, so many maneuvers that you can do that could reliably tell you that the person is having more of a psychosomatic hemiparesis versus genuine hemiparesis, that you might even not need to send him to have an MRI or CT scan or whatever. So I think that would be my take on things with regard to investigations. History taking, physical examination, then you have to be pragmatic, and that's probably the best you can do. The last question, Herman, I forgot. So,
how would you communicate to a patient that their pain or symptomaቸው is related to their thoughts, or ማለት እንዴት ነው አድረስ የምናደርገው? ፊዚካል ችግር የለም የሚለውን እንዴት ኮሚዩኒኬት እናደርግ የሚለው ጥያቄ ነበር።
so that's a very nice question, which means it's a very difficult question, right? So it's about, it's not only about how you say it, it's about the relationship that you have with the patient. So with my patients, so with my experience, I'll try to build a very good relationship with my patients. So over time, we discuss. I try to know as much as possible about their lives, about their childhood, about their time in school, about their interpersonal relationships, about their family issues, family problems. So I try to understand them in as much depth as possible. And that process by itself is very important, because the person is looking at me thinking, okay, so this person, this physician, is interested in me. He's trying to know all sorts of things about me. So that kind of leads to the deepening of the relationship between me and my patient. And there comes, with that will come respect, with that will come the goodwill of the patient as well. So that means when we get to the place where I need to talk to him about his diagnosis, he already has a better confidence in me and my intentions. So I think most of the job is already done. But in terms of communication, what I would try to do is I would try to go to the specifics. So I would give him or her examples of problems in their lives. So I would tell them, do you remember when we talked about your problem, your pain 3 months back? At that time you were having a problem with your son. Then when we talked, about your back pain, 6 weeks back, then you were having issues with your husband. Then last week, when you had that, very difficult headache, it was preceded or triggered by, it was preceded by you having an altercation with one of your neighbors. So I said to them, do you see any pattern? Do you see any method to this, any pattern to this presentation? And usually, you help them, you nudge them a little bit here and there, and people are smart enough to understand what you're saying. And they usually would come with their own explanation, and they would tell you, it seems like, whenever I'm having problems with people in my life, then it seems like, my problems, my physical symptoms worsen. So usually it's about enabling the patient or the person to identify or to make the link between the psychosocial stress and their emotional difficulties and their physical difficulties. So it's not you telling them, it's you helping them identify the link between the two. So by the time they go out of your room, they're not thinking, oh, that doctor told me that it's all in my head. They'll go out thinking, oh, it seems like there is some kind of relationship between my body and my emotions, and my body and my interpersonal life. I don't know. That would be the way I will handle it. But I have the luxury of being a psychiatrist. internist, right? So, as a general practitioner or as an internist, then you have the time to build that relationship or not. I don't know, but you can. I'm hoping that you can take bits and pieces from this approach that I described and kind of integrate it in your approach.
Yeah, thank you በጣም so I think 19 ደቂቃ አርፍደናልና ብዙም ሰው እንዳናስጠብቅ በጣም እናመሰግናለን ዶክተር ቢኒያም በጣም ነው የምናመሰግነው ለፕሬዘንቴሽኑ and everyone actively everyone was also በጣም actively engaging. Thank you everyone. ሊንኩን ለሞላችሁ I think ፕሬዘንቴሽኑን ቀጥታ በኢሜል ሼር ማድረግ እንችላለን። በተጨማሪም ቴሌግራም ግሩፑ ላይ ይኖራል and for እንትኑ ለክሬዲቱ በ2 እስከ 3 ሳምንት ሊፈጅ ይችላል። ኢማ ኮሚዩኒኬት ያደርጋችኋል። በጣም እናመሰግናለን። መልካም እሁድ፣ መልካም ሳምንት። ተጨማሪ ሴሽን ደግሞ currently if you guys are interested in fertility ላይ Clubhouse ላይ active discussion አለ። እዛም join እንድታደርጉ ጋብዛችኋለሁ። Have a good night. Thank you Dr. Benyam በጣም እናመሰግናለን።
Thank you everyone. Thank you everyone for bearing with us for the past 2.5 hours or something like that.
Yeah.
But it was a pleasure. I really enjoyed it. So thank you Yetenaweg, Hermon, Yetenaweg, Ima, our participants. Thank you.
Thank you.